one of the thing, and I could be wrong in my observation, and again, I'm observing from outside looking in, is, and I am looking at the structure of the PHA system itself. Because of my interest in public health, I'm looking at how public health and rural health services is operationalized within this system. And the key position seems to be the director for public health. Is that office responsible for the community health post and rural health services, or let's say primary health care?
Yes, correct interpretation. So you'll find that the structure is correct. It's how we're implementing it, I think. The structure is right. You've got a public health and a clinical health. That's the rationale behind the whole operation of the Provincial Health Authority. But what I've seen is that we've got, at the national level, there's no real standard set, because provincial health authorities themselves are now creating their own standards for their own, even the hospital structure. I'm beginning to see that even the hospital structure is changing because it's not aligned to the national structure, where, in fact, in one hospital, you can have a super specialist that should be in a certain hospital, like maybe a regional hospital should have that super specialist, rather than having it at another province. So now you're basically not following the standards. You're having a super specialist in one hospital because he's being paid more in one hospital. So the PHA and the political leaders decide that this hospital should have a super specialist without considering that, in fact, if you do that, you are undermining the national standards, because you need to have an aligned system. If you have the systems aligned, then you have the budgets that are done right. You have the human resources that are there for that purpose, not for, okay, because of political thing, I'm going to use my hospital to be a super specialist, so I can get a super specialist with this, neurology specialist in one hospital and then another. So you basically destroy the equity of services to the whole country by having a super specialist in one hospital and you don't have others in another. And this is why the human resource component of defining what services is provided in which level of facility is critical. Otherwise, you'll end up having PHAs deciding, okay, I'm going to have a super specialist because I just think I've got this particular problem in my location, so I have to put it there. So you end up having a super specialist in that hospital without thinking that, in fact, the other hospitals are missing out. In fact, the whole country is missing out, because that super specialist is required for the whole country, not just for one provincial hospital. So that sort of thing is being done, and I'm a little bit afraid of that.
Is it because PHA has been given authority to make those decisions?
Exactly. What you're saying is right. You see, there's no oversight provided. And only the standards can provide those oversights. That's why I keep referring to having those standards done right, then you'll end up having a clear map of how the whole country system is operating, not just one PHA determining all this, or one political leader saying this and you end up doing that. That's why this difference between politics and the bureaucracy also becomes really critical, because politics can actually determine a whole lot of things that can become irrational if the bureaucracy does not stay and make proper analysis on what. Oh no, let's hold it a little bit and work out how rational that is. What will the money look like for the country, not just for that particular province? How will I invest? How will my country benefit? That sort of thing that I see. Maybe people don't fully comprehend that, I think.
So if we were to use an example to illustrate what you were just describing, let's say cancer services, because cancer seems to be the hot topic on the table. How should it be organized according to what you just described, national down to provincial?
Okay, when I was secretary, we also had the issues at the Angao Memorial Hospital for the cancer therapy for radiotherapy in Angao. And in fact, we worked very hard to see if Angao could be the cancer specialist hospital for the country. At that time, we designated it as a regional hospital. So Leh became the regional hospital for the Mamase region. So the cancer specialist would be done there, but because it had a specialty, then it would also take up the role of a national referral hospital. That's how clearly we thought it would go. So the cancer therapy would have been done in Leh so that it will cater for the whole country, not Port Moresby as a national referral hospital. So if they clearly define their functions, then we would have them done like that, so that all specialists or for all specialist treatment for cancer get done in Leh as a national referral hospital for cancer. So that would have clarified a whole lot of things. Then we would have had all cancer treatments done in Leh for the country. That means all the specialist care, for requiring senior specialist requirement would end up in Leh. That means all the super specialists for cancer will be all based in Leh, so that all the cancer patients would be referred to Leh as a national referral hospital for cancer. That's a basic understanding, at least we had at that time. But then we ended up having, and now you see that. That's why it's critical to have those standards worked out very clearly for what specialty in cancer or radiology or whatever specialty, you clearly define it. And then at the lower level, you have, in fact, one of the things I also discovered is that health is so complex. I found out, talking to Mr. Kali at that time, who was then secretary for DPM, he told me, "Oh, look, you got you have just two classes. You're graded as a class at that time for each human resource for the department. Class 1, class 2, and so on." But then I realized in health we had different specialties, up to about 28 different cadres of workers, complex area in health, which required those specific detailing of each facility to those level of requirement as required for health service delivery for the population. And therefore, you would have a clearly defined system for the whole country in each level of facilities that was defined under the National Health Service Standards. Sorry, I got away a bit with that, but I think it should clarify most of the things that we're trying to address, or hopefully we can address in the country.
I remember that when I was in, I think, medical school and just coming out, and Angao was kind of accepted as that would be where the cancer center would be. And in fact, at the time I was training to be a pathologist, and I had one of my senior colleagues graduated and posted to Angao. I don't know what happened. I have never worked in those key decision making roles. Unfortunately, I moved out, and here I am looking in and trying to make sense of it.
Yes, what we are discussing right now is really critical because you see, we had thought that Port Moresby would be okay, would take care of everything that's being missed out, but it also could take care of a particular responsibility, like we're thinking of cardiology services, because at that time Prof. Keva was a specialist already doing that, and all cardiology things would be specialized there. Then we would think of other place like Hagen, if it became a it would have its own specialty, maybe into infectious diseases or some thing. Then we thought of Rabaul as another regional hospital where it will take its own specialty but become a national referral hospital as a way of decentralization. But then we allow services for different things to be taken care of in a very specialized way in each of those regional hospitals. So those are the sort of thoughts we had at that time. But I can't say exactly how that went. And sadly, I think back to what I was saying with regard to planning and looking forward, we do not usually make at least honest assessment before we move on. We need to make honest assessment of what was tried, what failed, and admit that they failed because of this. And then we move on by knowing what we must do for the good of all in the next set of standards and plans that we do. By not doing that, we are failing ourselves, sadly.
That brings to my next question I wanted to ask was rural health services. In terms of rural health services, I understand under the current PHA structure, there is no 8 post, or the 8 posts and health centers are now under the community health center structure.
Thank you very much for that. I think that you're sort of allowing me to really clarify the concept of community health posts. That time we had 7 levels of facilities. And what I personally wanted to do was just use the community health post as a example to really transform health services. That's why we had the focus on women and children, because we had very high maternal mortality rates. And then obviously public health. So those were the 3 main things that now make up the current design by ADB. You'll see that there are 3, it's a cross design in most of the facilities. There's a cross design. And cross design, again, was for the community health post was developed because PNG is a Christian country. We were hoping to have that visibly shown through health facilities throughout the country. So one arm would have maternal health, the other child health, the other public health that will look at general things. And then you would have an administrative block for the community health post design. So that was the original design for this. I'm raising this because it would be an example for those 7 levels of facilities, that in each level would have a facility function given, and that facility function would have that function clearly articulated: maternal health function, child health function, and a public health function. So the community health post would have that, and the human resources and assets, all the equipment, medical supplies will all align with what that function of the facility and how that function would operate to execute its function as a way of improving health services in the remote rural areas of the country. So you will find the only sad thing I've now, in retrospect, visualized is that some of those community health posts have been placed in locations for political reasons. And sadly, that does not provide equity. Originally, if bureaucrats were involved, like the PHAs, if they were strict about what they must do for access to services for all, they should place those facilities in locations that were strategically located and easily accessible by everyone. Then you would have a health system that's operating effectively. That would go for the 8 posts. They would have had their own things, and then the sub-health centers and health centers as discussed by each PHA, not determined by the national level, but allow those standards to be applied by the local authorities, which is the PHA, and then the different facilities that were required by each province and each district and each LLG, following the political structures. So that's how an effective health system would be operating, so that you'll have even the costings done appropriately and done effectively, so that you have a cost-effective system that's operating for the whole of the health system. If you fragment that, I'm sorry, you end up misfinancing things without proper evidence.
Some PHA would still operate 8 posts if the LLG wanted it, but they would still have a community health center within a specific agreed geographical location that everyone can physically access.
Correct. I think that's they should that's the role of the PHA, to see what is effective in their province. They need to look at that critically and analyze and make those judgments based on equity, access to services, and making sure that their people are getting served the right thing. Get the proper referral systems done, like ambulances they go to pick up patients. They don't go to, only God knows what I've been seeing these days. They go and get drunk and bump into, doctors bumping ambulances into their, oh my goodness, sorry. I'm just saying this out loud because, it was unthinkable, not thought of when I was training to be a doctor. Sorry, but I got to say it.
I have a big grin on my face because that's exactly what I've been observing. Finally, I think one of the things that I wanted to ask you, and I think it will come back to the service standards that you described earlier, and its governance. Why you think governance is an issue for us when it comes to implementing, say in our case, health service standards?
It's probably the most important one. Thank you for raising that question. Governance is the critical part of, unless you have proper governance, as I mentioned, may have sort of mentioned by passing, unless you have the bureaucracy standing up straight and strong to provide guidance to the politics. That's why now, even our governance system, we say very clearly there's the difference between those 3 arms of government. So unless the bureaucracy, in our case, as doctors, well, obviously we're trained to be doctors when we grew up, but then as we went on further, I learned that, governance is a key part of all systems that are operating in any place and time. Unless you comprehend this, even if you're a doctor, you will probably misjudge a lot of things. So that's why it's really critical that all doctors, all people wanting to become managers of any sort should have an open mind about things, to be flexible, to be able to see what's happening globally and locally, to be able to see the nitty-gritties of what all the humans in your population are suffering from. Why are they dying? Why are they getting sick? You might find that I've been advocating this process for a long time. They're very, very basic questions. They're not complicated. Why are people dying? Why are they getting sick? What numbers are? What categories? Which geographical location? Basic public health. So critical to understand when you are going into a management position, so that you can give the right guidance and support to your political leader, who changes every now and then. But if the politics goes wrong, the politics are over guiding, are overstepping, then obviously your systems will fail, because politics is not meant to drive health systems. If we're serious about getting equity and access to services to our people and reducing morbidity and mortality, to all our citizens. For that reason, I think it's critical that we all have an open mind and train human resources who go into management positions to be an open-minded cadre of workers, just like yourself, I must say. I'm so blessed to have a person like you chat with me because, I can see that openness. You didn't get trained in public health. I mean, well, you would be now, but
Yes.
when we all grew up, I never got trained in public health. But then you see these things as you go. As a doctor, you were given basic principles of what why does that person have fever? You find out the facts about fever. That's basic public health. You're working out, oh, what's happening with this patient, So you apply that to the population as a whole. And then you get it right. And we all manage systems properly for the good of everyone.
Thank you, thank you. And I guess that kind of brings me to, I think, governance and the other issue that I always debate and discuss with friends is um, leadership. Again, it's a big issue, but when we have our specialties, when maybe I'm speaking for doctors, but it may apply to other health workers in a leadership role or in a manager role. There's a breakdown in leadership in terms of decision making and serving whose interest. And I've been always wondering, is it a breakdown of, say, moral values, belief systems, or self-interest overriding a collective interest?
Maybe I think what you just mentioned last, self-interest overriding the others would probably be a category 1, I think, because if you don't have self-interest, the Hippocratic Oath gives us a whole lot of things. It doesn't give you self-interest, does it? So when we take up oath as doctors, what's our interest? I mean, what was our interest in the first place to be doctors? Is it to just make money? And money is the other. Sorry, that's right. Self-interest and money. Obviously, money is very important, not undermining money. But the thing is, when you do this in a land of plenty, we're not in many countries where our countries, into every year droughts, and we get, we're not into that. Our country is blessed with so much. So when we talk about money, just have in mind that money is on our land. Our people are surviving without much support from anyone. When you think of it, majority of our people, 95, 97% of our people are already surviving by themselves, actually, when you think of it. So majority of our people are already surviving without money. It's how we actually mobilize the resources to get that money in for them to be economically viable, to be successful in health and education and doing whatever things are right for everyone. So that's why I think when we look at it, it's important to look holistically and make our decisions accordingly for the good of all, and not just for, because we are blessed, as we said earlier, we are blessed. The country is blessed with so much. There's no need for us to keep on thinking about ourselves. There's no need. Let's think about what the country can do for me. As they said, keep on saying, and do what your country can do for you rather than what you can do for yourself. So if we think like that, I'm very positive. That's why I'm passionate. I'll keep going home. I'll definitely go home. I'll be in the village all the time now to look at and see how I can do things for my own people in the village. I think that's my own personal ambition and passion right now.